Okay, well, we are delighted this morning. We have a very special guest, as you were going to hear, as today's Grand Round speaker. But before we introduce Dr. Gordon, just a couple announcements. First, I want to call your attention to the Jonathan Duchang-Zhu Memorial Lecture next week. This is a very generous endowment created by Jonathan's family. Jonathan had kidney disease and cocaine syndrome, and the family endowed a lectureship around educating caretakers around compassion. And we're so fortunate that Rachel Callender is going to be speaking to us next week. And then the following week is another one of our endowed lectureships, the Ann T. Bass Lecture Series in Hem/Onc and Stem Cell. We're going to hear about the future of haploidentical transplantation in malignant and non-malignant diseases. I think in many ways the future is now. If you're aware of the work that Dr. Bertani is doing in particular with Paul Grimm and Dave Lewis and others on dual immune solid organ transplants. So this is a really exciting field in general, and we're very much looking forward to that grand rounds as well. As always, we will start with our land acknowledgement, and that we sit on the ancestral land of the Mweka Ohlone tribe. Was and continues to be of great importance to the Ohlone people, and consistent with our values of community and inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native peoples. And then also on this slide, just from a housekeeping, MOC, CME point of view, the information is there on the left. All right, we have quite a few announcements this morning. It's that time of year where we're starting to gear up for our 15th annual Pediatrics Research Retreat on Thursday, the 25th. It's just a wonderful opportunity to meet some of our new faculty, especially to hear from our trainees. So please submit your abstract. It's a really fun event, as you can see from the picture. And then we have a couple great upcoming MCHRI seminars. We're going to hear about geopolitical unrest, how aid sanctions impact global progress in maternal and child health. And then very pleased that Amanda Williams and Joachim Profit are going to present on the California Maternal and Perinatal Quality Care Collaboratives and the exciting work that they're doing addressing perinatal health equity. And there's some exciting new grants and a lot of new things to talk about there. And then I want to bring this to everyone's attention. We are working very closely with the associate chairs of DEI in the Department of Medicine, with the School of Medicine's Office of Faculty Development of Diversity, and with others to really create a survey that we think will uniquely capture culture and demographics within the department. This is a very carefully vetted survey using validated measures, and we think it's going to provide incredibly important information for our two departments together. And so we want everyone to be looking for this. We have taken extra measures to make sure everything is strictly anonymous. We want to understand the current experiences and demographics of faculty and staff working in our departments, so we can identify opportunities to further improve the culture of our workplace. It's confidential. It takes less than 10 minutes to complete and includes questions that are all optional. So please be on the lookout for that. Having a very high response rate is just going to be critical to the success of this work. We are calling out for our PIPS mentors. I hope you all know the Pediatric Internship Program is a very innovative program in the School of Medicine that brings first-generation URM low-income high school students from the Bay Area into our labs for the summer. It's a wonderful opportunity for everybody, all levels of folks, to serve as mentors. We've had medical students serving as mentors all the way up to senior faculty. And really Allison Guerin and the whole team that run PIPS. It's quite an inspired program, not just because of the curriculum for these young people, but also some of the things they do to help the families with things like college applications. And going into its third year, it's really been tremendously successful. So we just keep growing it and really always looking for new opportunities to bring in new mentors. It's a really joyful program, and so encourage people also to come to some of the PIPS events in the summer. And with that, we had we had to arm wrestle to see who got to introduce Dr. Gordon. And Catherine is one of my oldest and dearest friends, and it's a really special occasion to have Catherine here. And so Laura Bacharach's going to do the honors of the introduction.
I won the arm wrestle.
You won the arm wrestle.
It is a genuine honor to introduce my friend and colleague, Catherine Gordon. I've known Catherine, I figured out, for at least 2 decades. We met through our mutual interest in as pediatric boneheads. And then we got into discussing the joys and trials of academic medicine, parenting, and you name it. Early in her career, I tried to offer Catherine some mentoring support, but there's no question that the roles have been reversed, and it is thrilling now to see how much I rely on her for guidance. She's definitely someone who serves as my role model of excellence. I'm going to keep my remarks very brief because the most important thing is to hear what Catherine has to say, but I'm going to say a few things. Unquestionably, Catherine exemplifies a quadruple threat. She's a superlative clinician, both in adolescent medicine and endocrinology. Her basic and clinical research portfolio is massive, with NIH and foundation grant funding, hundreds of papers, reviews related to bone health, adolescent reproductive health, and transgender care. Catherine has contributed enormously as an educator through publications, invited lectures, and mentorship of myriad medical students, residents, fellows, you name it. And she has a special focus on fostering the medical careers of women. Catherine's held major leadership roles, including Division of Chief Adolescent Medicine at Boston Children's, Vice Chair of Clinical Research at Brown, Division Chief, University of Cincinnati, and she was the first woman ever to be named as pediatrician in chief at Texas Children's Hospital, and she was chair of pediatrics at Baylor College. Through her remarkably productive career, Dr. Gordon has been a shining example to me of resilience, humility, ethical behavior, and collaborative spirit. And her leadership style is one of quiet strength that fosters trust and a willingness to collaborate. She stands strongly for her principles, and her expertise and advocacy for care of transgender youth precipitated her ouster from office under Governor Abbott in Texas in May of 2022, only a year after arriving there as the first ever physician in chief. With remarkable grace, she has exited this role. The NIH was fortunate to recruit her, and she is now the clinical director at the National Institutes of Child Health and Human Development this past year. Thank you, Catherine, for your leadership. Thank you for your friendship. Thank you for your mentorship. And let me stop here and let Catherine speak to us. Thank you.
Thank you for that very, very nice introduction, Laura. Well, very good. Thank you so much for the kind invitation, Laura. David Moz, Mary, where is Mary? I appreciated the kind things that she said. I haven't been to Stanford in about 10 years, and I hardly recognize the campus. It's really amazing how much it's grown, and I have connections to so many of you, so it's truly an honor to be here. So over the next 45 minutes or so, as a pediatric bonehead, I'm going to talk with you about how bone density and body composition are evaluated in adolescents. We've come a long way. We've still got a ways to go, just what we've learned, and as well as the gaps in knowledge. And then I'm going to jump right into models of estrogen deficiency. Thought a lot about this as a endocrinologist and adolescent specialist. Anorexia nervosa, very common, premature ovarian insufficiency, and then transgender youth, as Laura alluded to, and then to think about paradigms, treatment paradigms for kids and teens. So I always have to start any of my talks with this slide because a picture tells 1,000 words. So we have on the y-axis bone mass, and then you see over time on the x-axis age. And I think you can see clearly that assigned males at birth have a higher bone density throughout the age spectrum than assigned females. And unfortunately, in both age groups, there is a loss of bone mass as a person ages, but more precipitously in females because of the menopause. Especially interested in that dip down because of the patients I care for with POI, premature ovarian insufficiency, we're going to talk about, who dip down much sooner than they should and before they establish their peak bone mass. Laura Bachrach is truly one of our pioneers who got me into the pediatric bone health field many years ago now. Neville Golden is right behind her there. We've all been working in the space. It used to be about 8 or 10 of us in a room, and now there are bone health specialists throughout the country, which is really inspiring. And we're going to talk about each of the tools that you see on this kind of montage of images. My research team, I've run a clinical translational research team, started right out of fellowship, which has really brought me a lot of joy. And what you see on this rather busy slide are diagnoses that are associated with bone loss, associated with direct bone loss or inadequate accrual over time. So a young person not achieving their peak bone mass. The diagnoses that are bolded are groups that I've taken a special interest in. I'm interested in all of them, but my team has tried to take a deep dive and think about mechanisms of bone loss, lack of accrual, and some of these, and you'll hear about them later in the talk. So just to get started, so when I was an adolescent fellow, endocrine adolescent fellow 100 years ago, I was seeing a lot of female athletes and got interested in this concept of the female athlete triad. So the American College of Sports Medicine in 1992 coined this term, which was defined again at that time as disordered eating, amenorrhea, and osteoporosis. And over the years, there was a lot of question as to what is disordered eating and what is osteoporosis in a teenager. And there was the understanding that anorexia nervosa, a very common diagnosis, was the extreme end of this continuum in many of our female athletes. So in 2007, there was a rethinking of the female athlete triad, and it was reconsidered to be a spectrum disorder. And I really like this image by Mary Jane D'Souza and her colleagues at Penn State, where at the top you see the green light, the optimal energy availability, which leads to normal menses, eumenorrhea, and then optimal bone health. And you see how an adolescent can slide down to the red zone with low energy availability, functional hypothalamic amenorrhea, and then osteoporosis or a bone density, bone structure that's predisposing to fracture. And I over my whole career have watched adolescents slide up and down. And I also like that it's at an angle because it can be really hard to push them up to that green zone. But thinking about energy availability is what's key, getting away from ideal weights, ideal BMIs. Or is the correct term read as? So there was another panel that got together, relative energy deficiency in sport. This was the International Olympic Committee consensus statement that the triad was too restrictive. They made that point again, but again embraced that concept of reduced energy availability. It also allowed us to think about those male athletes who came in who were also not eating enough and were expending too many calories. So how do we evaluate bone health in a young person? So we start with high-tech tools like a growth chart. We, as endocrinologists, we love growth charts and thinking about if a child is tracking and if they're proportional weight for height. But today, submit to you to think about it in terms of the bone accrual curve and how it should mirror that curve. And I have a slide to the right I put in there in Neville Golden's honor that shows a rate of change curve for DEXA. Neville and I have taught together a lot in workshops, and I think this beautifully shows a patient with anorexia who was going the wrong way. Instead of mirroring what's happened with that height curve, is starting to drop in terms of their bone mass. And so we would be very worried that she would enter young adulthood with a compromised peak bone mass. So here's the clinical workhorse, DEXA, dual energy X-ray absorptiometry. I have a grown woman, an adult, on the scanner to make the point that we use the very same scanner in adults as we do in children and growing teenagers. DEXA provides a two-dimensional measurement of bone density. It doesn't take into account the depth of the bone, so it can be confounded by bone size. And you're probably asking, well, why would you do that? Bone is a three-dimensional object, but we do it because we can get away with a whiff of radiation, very small radiation dose, and we have normative data now for children and adolescents. It's also relatively inexpensive, it's widely available, it's precise, it's fast. So there are a lot of reasons that we have it in our centers, but don't do this at home alone. It's really important for children to work with one of us to help you interpret these measurements, especially in children and adolescents with chronic disease, because they can have a distorted body composition and then those smaller bones, and it can be hard to figure out sometimes what's going on. In the research setting, we've had the opportunity to think about the peripheral skeleton. DEXA, which I just talked about, measures the axial or the central skeleton and measures body composition. Either standard PQCT, which you see there, the green gantry, or high resolution PQCT, which is like a virtual bone biopsy. It's looking at the peripheral skeleton. And in my view, that's more informative, because children and adolescents who are out on the basketball court, they tend to break arms and legs rather than the hip and spine. So it gives us a more clinically relevant measure. Again, the extreme CT, the high resolution PQCT, is the larger device in the back. It's a bigger machine. HRPQCT is a great big machine that doesn't emit a lot of radiation because it shields itself, because one puts an arm or leg into the gantry, unlike DEXA, which is an open configuration, but they're both, thank you so much, Ingrid. They're both associated with a low radiation dose, and so easy to get through a human subjects committee for our clinical research. But importantly, high resolution PQCT enables us to not have to think about bone biopsies, and we can really look at structure and microarchitecture. I've done a lot of work with anorexia nervosa as a combined endocrine adolescent fellow. There are so many endocrine alterations in patients with restrictive eating disorders, and have got interested as a fellow and continue to be fascinated by what those hormonal alterations do to physical outcomes. And a few years ago, got interested in how stem cells were even altered. So mesenchymal stem cells, or the MSCs, as you know, are hormonally driven either to become osteoblasts ultimately, or to differentiate into fat, into adipocytes. And patients with anorexia nervosa have that perfect storm: the low estrogen, the low IGF-1, the high growth hormone shunts those MSCs towards fat. So it's a paradoxical situation where we have patients with very little subcutaneous fat who start accumulating fat in their marrow. And it may be a compensatory mechanism because they tend to have hypothermia. But whatever the reason, it explains why over and over in our studies and those of others, bone formation is compromised because their MSCs are going the wrong way. We've had the opportunity, using knee measurements by MRI, to look at the T1 signal to assess how much fat is within the marrow, and then by MR spectroscopy, which you're seeing at the bottom of the slide, to look at how much water is in there, the water peak, and also the saturated and unsaturated fat. So we can get a lot of information about what's going on in the marrow. And again, as a clinical investigator from a human subject standpoint, we don't even have to think about a biopsy. This is all non-invasive. This is a pretty striking picture, but over the course of my career, I've worked in academic centers where we follow over 300 patients at any time who have restrictive eating disorders. They have either anorexia nervosa, they have RFID, or they have bulimia nervosa, or a combination thereof. And patients with anorexia are at the far end of that female athlete triad spectrum. And there are a number of hormonal abnormalities that you see here on the slide. I've alluded to some of them. And the two abnormalities that we've had a real interest in are the low estradiol, which ultimately leads to that low IGF-1 due to the malnutrition, and then DHEA, dehydroepiandrosterone sulfate, which is a precursor of estrogens and androgens. And we're going to get back to that point. So what we know about anorexia and bone is bone density is about 25% below that predicted for age and gender. And we know that the fracture risk can be as high as 7-fold increase in these young adolescents. the skeletal deficits appear to be somewhat irreversible because Laura Bachrach has shown that there is a critical window for accruing bone. And if a young person misses that window, it's hard to catch up later on. So when they start getting to 18 and 20 and close to when they should be accruing their peak bone mass, it's hard to catch up at that point. And then we've come along a few years later and mechanistically have started thinking about what's going on within the bone marrow that might explain why that happens. And again, we think that it's related to that low bone formation. Amy DeVasta, who was a resident here at Stanford many years ago, is now the division chief at Boston Children's. And I have really had a fruitful collaboration thinking about mechanisms of bone loss in these patients. And as some of you know, I'm looking at the adolescent team. When these patients are hemodynamically unstable, we put them on complete bed rest. And I've always had ethical qualms as a bone health enthusiast, and I've attended many years on adolescent medicine, putting patients in a situation who have low bone formation anyway, and then I know I'm going to change their bone turnover, putting them on bed rest. We know when we send astronauts to space, microgravity situation, their bone resorption increases. And we had worried about when our patients are not weight bearing, what happens. So Amy and I, several years ago now, admitted about 30 patients to Boston Children's. As you can see on the top left, that when we put them in the hospital and encouraged them to eat and work with a dietitian and a therapist, they gained weight. So we were encouraged, we helped them to gain weight. But then as they were in the hospital, we did markers of bone turnover. So we did a marker of early osteoblast function, BSAP, or bone-specific alk phos. And I want to call your attention to that finding. It decreased over those first 5 days of the admission. So weight is increasing, they're on bed rest, they're eating, but bone formation is going down. Osteocalcin, which is a marker of bone turnover, went up. And then NTLA peptides is a bone resorption marker, went down and went up. But we were really struck by that BSAP, the bone formation going down over time. Amy then got a K23 award for fellows who may be out there. And we used a vibrating plate at the bedside for 10 minutes a day and showed that using that plate, we could avoid that decrease in bone formation. And this is something that we're exploring. We also had to be very careful because these patients can vasovagal. We had to come up with a way for them to hang on as they were on it looks like a scale, a platform each day, but it is a promising non-pharmacologic way to target that low bone formation. Other therapeutic strategies, we explored DHEA plus a low-dose combined estrogen progestin oral contraceptive pill, and then transdermal estrogen has been another area of interest. This first slide is from the Mishra group at Mass General Hospital across the city in Boston. When I was at Boston Children's, that team, my hat is off to them, studied 100 adolescents with anorexia nervosa for 18 months. And you can see on this slide that the red bar are the untreated patients. So they had a restrictive eating disorder. They were participating, receiving routine care. The green bar are patients who are on transdermal estrogen, and then the green bar are the healthy controls. And I don't even need a pointer for you to see that the patients who were treated with transdermal estrogen almost approached what the controls accrued over that period of time. So this is lumbar spine by DEXA, and at 6, 12, and 18 months, there was a nice increase in bone density. And that team has since been trying to help those patients catch up in their skeletal accretion by giving an anabolic agent. They've been looking at growth hormone and infusions of IGF-1 along with the estrogen, but to my knowledge, those trials are still ongoing. Across the city, Amy DeVasta and I were working with older adolescents, and this was an FDA-sponsored trial. DHEA is classified as a supplement. You can buy it over the counter, but if you use it as a treatment, then one has to get an investigational new drug application. So every 3 months, we were sending data to the FDA, and they would only let us study older, older adolescents. So they had to have evidence of fused epiphyses before we gave this combination therapy. Remember, these are older adolescents who were close to their peak bone mass. And what we were able to show was an arrest of bone loss. These are spline curves. If they're, I think I might see Jen in the back, statisticians. So you can see the patients on placebo went down and then kind of stabilized at the total hip, went down more consistently, same at the total body by DEXA. But we saw almost a flat line, and we're pleased about that in these older patients that we had arrested bone loss. We also, from those DEXA measures, took the hip data and turned it on a cross-section and used what's called the hip structural analysis program. For any engineers in the room, we were able to look at the cross-sectional area of the bone, the cortical thickness of that upper femur, the section modulus, or the bending strength, and the bone strength index, which is similar to the cross-sectional moment of inertia. So these are different aspects of bone strength. And as you can see, the patients who were treated, there's a positive change. The placebo, it was negative, and there was an interaction effect. So there was a significant difference between our treated patients and those over 18 months who were on placebo. So we were especially excited about this, just to put it in context, that maybe this was going to impact fracture risk over time in these older adolescents. So in conclusion, unfortunately, hypothalamic amenorrhea, this is my first section, is common among adolescent girls and young women. It's truly a public health issue, and the prevalence of eating disorders had just tripled to quadrupled related to the COVID pandemic. So adolescent specialists are very, very busy trying to help these patients. It's important to rule out organic reasons for amenorrhea and low bone density, remembering that athletes should have a higher than average bone density. So if we see an even slightly low bone density in that group, we should be worried. Prevention efforts are needed to prevent the development of eating disorders in the first place. And there's a lot more work to be done. Stay tuned at what's going on at NIH, really thinking about the ideal transdermal estrogen and other anabolic agents that may be needed to promote bone formation. So I want to shift my work at NIH. I'm in the intramural program, so I have a lab there. I am given a treasure trove of funding to try to ask important questions, and out of coming out of the blocks, I'm trying to build a destination center for patients with premature ovarian insufficiency. And many of these patients, these are 11, 12, 13-year-olds who come in with fatigue and maybe delayed puberty, and they and their families find out that they're going into menopause. And often it's due to idiopathic causes, or it might be autoimmune oophoreitis. Then there's a large group of patients who have gotten through their cancer diagnosis, but they're developing ovarian insufficiency because of the chemo and radiation they received. So any way you look at it, any etiology, it's very difficult for these families. It can be a shocking diagnosis. And we're trying to put together resources for these families, and also to learn more about what the optimal treatment regimen should be. I would also say that it's an opportunity to engage pediatricians and gynecologists. There's a gynecology team at NIH who are looking at fertility preservation. And so it's very exciting. I'm thinking about estrogen replacement and etiology, and then they're working closely with me to give some options for these families around their future reproductive options. POI used to be referred to as ovarian failure. We're trying to get away from that because we've learned that insufficiency is a better term. For starters, it's nicer for the patient. It's nice. failure never has a good feel. That's not encouraging for an adolescent, especially a young person who's been through a cancer diagnosis. And insufficiency is more descriptive because these patients, their ovarian function can wax and wane. Adolescents can get pregnant. Adult women can get pregnant who have this diagnosis. So they can be intermittently ovulating, but it captures what's going on. These patients often present with amenorrhea, typically 4 to 6 months before it comes to attention. And there needs to be 2 FSH values, follicle stimulating hormone values, on 2 separate occasions to nail the diagnosis. And then the evaluations after the diagnosis, this is where we're trying to carry out deep phenotyping of these patients. So DEXA scans, that clinically relevant measure, but then sending them down the hall to the new HR PQCT scanner to look at the peripheral skeleton. Cardiovascular health screening, we're working with the cardiologists at NIH to identify some meaningful endpoints, which I think will be very helpful in thinking about dosing strategies for estrogen replacement. We have a team of geneticists. We're interested in what their underlying genotype is, but also interested in whether genotype predicts response to therapy. So there's some genotypes that represent a robust, reflect a robust response to estrogen compared to others. So I think that will be interesting to follow. The fertility counseling, as I've mentioned, but importantly, emotional counseling as well, because this is a real loss for these patients. There have been studies showing that they can have a lower self-esteem, and shyness is more common in adolescents, especially with POI. The therapy options, whenever possible, using transdermal estrogen. It is not metabolized in the liver, so it avoids those first pass hepatic effects. There's lower thrombosis. We're not altering those clotting proteins because transdermal is not metabolized. It doesn't go through, again, the liver. And it's thought to be a more physiological replacement because when we give a patch, it's 17 beta estradiol. The ovaries make 17 beta. When we give oral estrogen, we can give 17 beta, but more commonly in an oral contraceptive pill, it's ethinyl estradiol, which is not, there's some data showing that it's not as beneficial for bone. It's just giving back the identical hormone itself. And that's something our lab is trying to better understand. But longitudinal data are needed, and oocyte preservation is becoming standard of care, especially for cancer survivors. And so we're trying to think about it in that idiopathic group as well. So in summary, POI is an enigmatic disorder. There's a lot to be learned. Patient, think about it. And for trainees who are listening today, a patient with delayed puberty, irregular periods, amenorrhea, unexplained low bone density or fractures, and then in adult practices, infertility can be the presenting sign. Many different etiologies. There can be serious consequences for bone health. And we know the longer the diagnosis before treatment, the worse for bone as well as other tissues. So again, more research is needed. So my last section is about pubertal blockade in transgender youth. And the way I got into this, Norm Spack, Dr. Norm Spack started the first pediatric transgender program in the US. And he started it back in 2007. Many years before, he was a mentor and friend. He's still a mentor and friend. He did a double fellowship in adolescent medicine and endocrinology and said, why don't you do that? And my response was, I didn't know you could do that. And then he really sort of paved the way for me to become double boarded. And I had the opportunity, this was back in the 1990s, as an adolescent fellow to provide primary care for transgender youth. And he was treating them on the side in his practice, and eventually got support from Boston Children's to start the first pediatric clinic. As a bone person, anytime I give talks like this, I've been asked, well, what happens to transgender youth when you block puberty? And my answer was always, not sure, but sex steroids are important for bone accrual in adolescents. We know that, so it needs to be studied. So just to make sure we're all on the same page, as endocrinologists, adolescent specialists, we have the ability to manipulate puberty, to block it by giving a GnRH agonist, gonadotropin releasing hormone agonist. GnRH should be secreted in a cyclical fashion, but when we give a GnRH agonist, we give a big dose, either by an injection or an implant, then that blocks secretion at the hypothalamus, blocks LH and FSH secretion, and ultimately this is a assigned female. Ovaries or testes are not making either estradiol or testosterone. And the question has been, by doing that, we're helping the young person, because if they have gender dysphoria, they're in great distress, but what happens to bone? And in my view, there are a lot of myths circulating as to what happens because we simply don't have the data. So there was an RFA 4 years ago now from NIH looking at medical consequences of transgender medical care. And I thought, if anybody should do that, it's our team. So we had a 2-site team, Boston Children's and Cincinnati Children's, and happy to say we got the funding on the first try, and off we went. Very excited to get some answers to this. I was the co-PI with Heidi Cockworth at Cincinnati Children's. Upon coming to NIH this summer, Dr. Amy DeVasta is now the co-PI, but I have permission, thankfully, from NIH to keep working with the team. The concept there is the extramural versus the intramural funding from NIH. The gender-affirming hormones, just to review, masculinizing would be testosterone to an assigned female at birth. Feminizing would be estrogen and or anti-androgens to an assigned male. And from a bone perspective, have been particularly interested in changes in body composition that might change the muscle bone unit and affect bone health. And the same in an assigned male to whom we would be blocking puberty and then giving feminizing hormones. As we go into this, I probably should have had this slide earlier. We consider a significant low bone mass as a BMD-Z score of -2. So compared to age and gender match controls, that would be the threshold of concern. As you can see, Mary Leonard, Babette Zimel, and I were on a panel together, gosh, Barry, 10 years ago, can't believe it, with the International Society for Clinical Densitometry. So the interpretation can be challenging. So pediatric bone health, as Laura, Mary, Neville, others have taught us, children, adolescents are a moving target. So every time they come to the DEXA Center, unlike an adult, their bone is a bigger size, a different shape. It should be moving, but as densitometrists, we have to take that into account and then figure out, due to the change in size and shape, what happened to density. So now we have normative data that's for the assigned male at birth, assigned female at birth, and then now we're blocking puberty. So how in the world do we interpret bone density? So which one should we use? Which one should we report? So in general, we use the reference data for the assigned sex at birth as we are beginning and blocking puberty. So there is consensus around that point. And then as we start to give gender affirming therapy, as we're going towards the preferred gender, that's when we start using the affirmed gender reference database. So this would be an assigned female, and we're looking at Z-scores using that reference data, and then switching over if we start giving testosterone. That would be the gender affirming care. In clinical research, we look at both. We like to know where the participant is coming from, so their biological sex and that assigned sex at birth, and then the affirmed gender. So we look at both and track it over time in these studies. It can also be helpful to correct or adjust that bone density Z-score for bone age if there is a patient with short stature and similarly taking the height for age disease score from the CDC curves and correcting for that with short stature. So the transgender patient who has short stature for age needs a lot more maneuvers. And I would definitely recommend that you get a pediatric endocrinologist involved or an adolescent specialist who has a lot of experience with transgender care. I really like this cartoon. Mary, I think you put this out many, many years ago. So where are we exactly? That's how we often feel in the pediatric bone field. So we have to consider a lot of things in interpreting bone densities, the stage of treatment. Are we going to think about the assigned sex at birth, the affirmed gender, both? Is this clinical care or is this a research setting? And throughout this talk, I'm going to be using AMAB, assigned male at birth, or AFAB, assigned male. So a lot of the transgender work, the transgender care work, was launched in the Netherlands, where the Netherlands were very open to this idea of individuals who did not feel comfortable in their assigned sex, their biological sex. And they started the pediatric clinics. They were the first to start it in the world. And again, my mentor, Dr. Norm Spack, went over to the Netherlands and learned from them. He shadowed them for many weeks and then brought their protocol back to Boston, which has been adopted by many of the gender clinics around the country. This cohort, they assembled a cohort of 42 assigned females at birth, 28 assigned males. They watched them over time during a year of pubertal blockade and then 24 months of gender affirming care. And we're going to get back to that. Something that I want to point out was they noticed, oh good, it's still there, that the assigned males at birth, the transgender females, had a lower baseline bone density. That's been a consistent theme that's been noted by in the Netherlands, but in the Dutch adult and pediatric studies. Navabi and all noticed the same thing, that the trans females had a lower lumbar spine, aerial BMD by DEXA, as well as a Z-score. They also noted lower engagement and exercise for those trans females. I've heard this discussed, that there's the risk of being teased on the ball field. A lot of times trans females are not the first to raise their hand with physical education classes or to go out in competitive sports. So perhaps reduced involvement in moderate, vigorous weight-bearing activity is at play. They are also at high risk for restrictive eating disorders. So trying to have a more effeminate body type, they'll restrict their eating. I've definitely seen that in our eating disorder program, trans youth who come and are trying to lose weight as a way to control their body image. So in conclusion, we learned from this article, it's important to really take a detailed history around physical activity and nutrition. Another study by Janet Lee at UCSF. Dr. Lee was one of the first to think about bone health in pediatric trans youth. Early pubertal trans youth had not been studied. It was more adolescents and young adults. And as part of an NIH-funded cohort, 63 American trans youth who were initiating pubertal blockade were studied. And they showed that low BMD-Z scores were found again in the trans females, the assigned males at birth, about 3 times the prevalence as in the assigned females, that calcium intake was very low, that they engaged in less exercise. So she also identified nutrition and exercise as points of intervention. And just to show you that, this is from Dr. Lee's article, and call your attention again, I'm scared to touch this computer. Low bone density, this was in the designated males at birth and designated females at birth. So you can nicely see there's a much higher prevalence. And that group, again, at these NIH sites also looked at the lumbar spine, L1 through 3, by quantitative computed tomography, and showed that in the assigned males, that cortical bone density here was much lower than trabecular, and there was not that difference seen in the assigned females at birth. So again, the assigned males, the trans females, are at much higher risk, it seems, for a lower bone density. And long term, we need to understand the implications of that if they grow up to have more osteoporosis and higher fracture rates. Recurring theme, Dr. Lee's group looked at another data set and again showed to the right of the slide here that the assigned males at birth at many skeletal sites, total body less head, lumbar spine, total hip, femoral neck, had a lower, this is a box plot, median bone density. That to the Vlaat group in Amsterdam. This was that cohort I told you about of adolescents who were blocked for a year. The D1 is where they met these patients. They started the trial. You can see there was a trend downward for these trans men after their puberty was blocked. Same for the older adolescents. All of these were trans men or assigned female at birth. And then at this point to the C24, they started getting gender affirming therapy. So these were patients who were getting anabolic testosterone. And in general, they had the most robust response. They also had a cohort of trans women, again, assigned male at birth, who their bone density went down with pubertal blockade, but like the trans men, had a nice robust response. So the take-home message from this is if we can get them eventually on gender-affirming care, there seems to be encouraging catch-up. So there are groups in the US that are similarly trying to capture that data. And I'm happy to say, before I joined the intramural program, NICHD was so concerned about this issue that they gave us a supplement to that R1 that we had to look out 2 and 3 years into receipt of gender affirming therapy. So our grant started out the study just looking at pubertal blockade, but NIH is interested in what happens when we start the gender affirming care. So it's cited maybe a next trip I'd be able to share those data. So I hope I've convinced you that DEXA interpretation is challenging in these adolescents. More is needed. We need to better understand the timing of pubertal blockade for a young person and the timing of the gender affirming care and the duration of each. And it's interesting, those who started gender affirming care in mid to late puberty were more likely to follow curves of the sex designated at birth. So looking at that a different way, the earlier we can start the pubertal blockade, gender affirming care, it helps cosmetically, the desired outcome for that young person. Dr. Spack has shown that over and over, but also seems to be more desirable from a bone density standpoint. My very last data I'm going to show, I mentioned that we've been interested in the fat bone connection. And just to remind you that our bone marrow progressively goes from being red, hematopoietic, to yellow or lipid rich. And this is a typical transition that happens over time. But if we block sex hormones, as we do in transgender youth, or happens in anorexia nervosa, there can be, excuse me, early yellow conversion to yellow marrow, which is lipid rich. So as we did for patients with anorexia, we had a protocol in Cincinnati and another in Boston where we were looking at the marrow composition in patients who were starting puberty blockers. And we, again, non-invasively, it's similar to an MRI that a young person gets for an injury, a sports injury. We're able to look at that distal femur and quantitatively and qualitatively assess how much is yellow versus red marrow. And then by spectroscopy, you see the region of interest there at the distal femur, and done consistently for all of our patients. We look at the peaks of water and the trans and unsaturated fat. This is a qualitative system. This is a system that Kirsten Eklund at Boston Children's developed, where you see the homogeneous yellow marrow there at the lower score. And then what's typical for an adolescent is having a heterogeneous red marrow and yellow marrow. So you see the darker pockets of red marrow, again, hematopoietic, versus lipid-rich streaks of yellow marrow. Number 3 is the healthy picture, believe it or not, even though it looks very heterogeneous. Transforming the yellow marrow, that low score, the 0, would be abnormal for a teenager. So we showed in anorexia nervosa that the controls had just what I said, the heterogeneous picture, but the patients with anorexia had transformed to all yellow, fatty, rich marrow. We then drew a region of interest at the distal femur and showed quantitatively, Shriver helped us, that there was more fat in patients with anorexia. And our hypothesis was that that would happen in patients who were blocked, transgender youth whose puberty was blocked. And lo and behold, Nasamayan at Cincinnati Children's showed by T1, this is a MR image, that transgender youth and the blue bar indeed had a lower T1 signal. And when we looked at the fat fraction, they saw more fat. So that was that quantitative measurement that we did later. And these pilot data have encouraged us to keep looking at this. That NIH-funded study I mentioned with Cincinnati and with Boston is going to be tracking these data in addition to DEXA and PQCT. So stay tuned. I think this is going to be a rich data set mechanistically to show us what's going on. So in conclusion, early pubertal adolescents undergoing blockade appear to have increased marrow fat that may compromise their bone formation. What happens when we start gender-affirming therapy, whether the osteoblasts wake up and we think they might, is unclear, but stay tuned. And there's concern for low bone mass, especially in those assigned males at birth. My recommendation is definitely in the trans female patients to get an early bone density so we know kind of where they're starting at the time of pubertal blockade. And it supports this concept of premature conversion of the mesenchymal stem cells, the red to yellow marrow that's influenced by the hormonal milieu, as we showed in patients with anorexia. Again, definitely, I'm asked the question a lot, should we get baseline DEXA measures for all transgender youth? Definitely for the assigned males at birth. Otherwise, letting the history guide you if there's a history of osteoporosis in the family or frequent fractures. And the fracture risk is unknown in this population. So that's what we desperately need to know and follow in longitudinal studies. I just want to end with a slide. I'm fascinated by thinking about the mechanisms of bone loss in these patients, but I've cared for many older children and adolescents who are suicidal. They are completely distressed, that term gender dysphoria. They're very unhappy about themselves and their body. They feel like they're in the wrong body. So in a suicidal teen with gender dysphoria, just a reminder that this therapy buys time. I've seen that over and over, can be life-changing and life-saving. And so in the face of a suicidal transgender teen, I'm not thinking about bone health. I'm interested in bone health in the long term, but I'm just looking at interventions that will save that young person's life. And I think that's an example of keeping our eye on the ball and doing the right things for patients. So I'd like to first thank, I have connections to many of you. There are many more people I could put on this slide, but I decided to restrict it to Mary. I know Mary just had to go to a meeting, but Mary has been such a great friend and collaborator, and Mary's the best. I know you already know that. And then others on the slide, I've enjoyed friendship, mentorship, collaborations. I've published with everyone on this slide, except for one person at the end, John Klein, who I have known since I was a med student, helped to inspire me to go into pediatrics. And we have worked very, very closely with the American Pediatric Society, the Career Support Committee, It's just a wealth of information and wonderful. And I'm so glad that he's now in your faculty. And I have many collaborators at many different places. Their pictures here are the ones whose data I showed today, and then the funding that's made our work possible. Thank you so much again for this opportunity to speak. We have 5 minutes.
Yeah, we do. Thank you so much, Catherine. I always love to hear you talk, and it's a real pleasure to have you here, visiting from the other side of the country. We actually don't have any questions in the chat from those online, but I'm sure there are some in the room. So we'll start with Neville.
Hi, good morning. Firstly, Neville Golden, adolescent medicine. Catherine, thank you. That was wonderful, as always.
Thank you.
A question about the adolescents with anorexia nervosa or restrictive eating. Do we have an oral bone anabolic agent either present or on the horizon? Because most of what we do really is anti-resorptive treatment.
Yeah.
And bone and gaining weight and whatnot is wonderful, but it just doesn't always happen and it takes a long time.
Yeah, no, I really appreciate your question. The question is about oral anabolic agents. And unfortunately for adolescents, we don't. There are some that have been shown in animal models to increase the risk of osteosarcoma, probably much higher doses than we would use clinically. But there are some of the, like the TNF alpha inhibitors that that help to kind of reinstate the osteoblast. But to my knowledge, and I'm really kind of pressing this, working with people at NIH from FDA, like maybe changing the threshold, inching down to 15-year-olds if we can get some promising safety data to help. We do. Other comment, Neville has done a lot of the important work around anti-resorptives, and even the anti-resorptives is just one side of that bone turnover cascade, resorption formation, and some of the safety data for bisphosphonates has been questioned, which is the classic anti-resorptive agent. So unfortunately, no, it's the short answer.
Thank you, Catherine, for a really beautiful review. I want to ask you a little more about what you're going to do for POI. So I have two quick questions. And number one is probably a decade ago with one of our fellows, we wrote a paper because it seemed like we were seeing a blip in idiopathic POI. And I'm wondering whether your research will try to get a sense of prevalence or incidence, because it seemed like it was going up, and what's in the environment that might be causing it. And I guess the second question relates to a little more detail about how you're going to define or describe or get data for the optimal replacement therapy.
Sure. Yeah, no, both great questions. So, Laura, remember that intriguing report, and it struck a chord because we seem to be seeing more as well. And we didn't know if it was somewhat similar to other diagnoses like autism, where you raise awareness and you seem to be seeing more cases. We might be, but it might be that we have our feelers out. We're better at screening for it. But to answer your question, yes, I am worried about environmental triggers, endocrine disruptors that might somehow be linked back and affect ovarian function. So we have a very long, we have just a script of questions that we'll be asking as part of this deep phenotyping. There also have been some questions about whether the HPV vaccine might be linked to POI. And I've had the opportunity to really study the meta-analyses and the reports that are out there. They're mostly cross-sectional reports or even small case series that show that. So I'm happy to say for the crowd, there does not seem to be a link between POI and the HPV vaccine, but stay tuned. I'm worried with you. Your second question, where we're planning to start is there expert opinion clinical guidelines for Turner syndrome that we tend to all use in our clinical practices, but without a lot of outcome data to support that. And the problem with doing clinical trials in this group, these are estrogen deficient patients. So one would not be able to have a placebo arm. So our first step is to take those Turner replacement recommendations and get a lot of outcomes. And then, like I said, to also genotype patients at baseline, to then study to get enough patients where we can see if the genotype predicts their response. And then looking beyond bone, looking at cardiovascular outcomes as well. Appreciate your question.
There are a couple of questions in the chat that I'll just pose to you, and hopefully we can get through them fairly quickly. One is, do transgender assigned males at birth have lower bone mass relative to transgender assigned females at birth, or is it tendency to osteopenia related to cis males? So when you say, I think my interpretation is that when when you say that assigned males at birth have lower bone density at baseline, is that compared to other assigned males at birth, or to?
That's right. Yeah. It's compared to other assigned males at birth, or the cis males. So the reference data is for their natal sex, if you will, and so they have been consistently lower, 3 times the rate of having a low BMDC score compared to those age match assigned males.
There's something without treatment that even before you start that puts them at risk, and therefore their risk is even higher when you start to suppress when you use GnRH analogs.
That's right. And exercise and nutrition seem to be the factors that we need to investigate more to be the culprits.
And the last question, I think, is probably long, but I will, the question's short, but I think the answer may be long. How do you decide when to liberalize activity in a patient with anorexia nervosa who's struggling to gain weight? It seems to me that is the,
Yeah, that has to be individualized. And my short answer is that is done in consultation with the dietitian and therapist who's working with that patient. It's hard to endorse moderate exercise in that group. And often I find the therapist can help me to do that. But I have to be, that one is truly a slippery slide. They'll say, but Dr. Gordon said I could run the Boston Marathon. It's like, no, that's not what Dr. Gordon said.
Well, thank you so much, Catherine. It's been really wonderful.
Thank you.
And thanks to everybody for joining us today.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.